My name is Christopher Bartley, and currently I'm a clinical fellow in behavioral immunology in the Department of Psychiatry. And in October, I'll be starting as an adjunct assistant professor in the Department of Psychiatry. In that role, I'll be building out our immunopsychiatry program, and at the same time, I'll be serving as a postdoctoral fellow in the Department of Neurology. There's so many things that excite me about my job. I'm an MD PhD. I'm a physician scientist, and what excites me about the role that I'm taking on is it allows me to combine my clinical work with my research. At that nexus, I think there's a real opportunity to really drive innovation in clinical care. And so the department's given me an opportunity to build out this immunopsychiatry program and then to integrate that with my basic science research to hopefully advance care for psychiatric patients. So my basic science research falls under the broad umbrella of behavioral immunology or immunopsychiatry. And in that area, we're really interested in how the immune system affects the brain. And so the brain processes information, and we now know that the immune system can release signals that alter how the brain processes information. If the brain incorrectly processes information, that could lead to psychiatric symptoms or psychiatric behaviors. And in particular, I'm interested in whether or not there are antibodies which are normally directed at microbes or infectious particles that inadvertently target the brain and alter how the brain processes information and thereby leads to psychiatric symptoms or psychiatric behaviors. My work really reinterprets the word vulnerable, and rather than thinking about vulnerable demographics, we think about vulnerable clinical problems. And there are groups of patients whose clinical problems don't really match any of the known diagnostic categories for any of our clinical services. And so there are patients who may fall at the intersection of rheumatology, immunology, neurology, and psychiatry. And none of the services know exactly what to do for that patient because that patient doesn't match their known clinical syndromes. I'm thinking of a patient in particular, a 38-year-old man who was diagnosed with schizophrenia in his late 20s. He's also found to have a rheumatologic marker, but he didn't have any of the clinical symptoms of that rheumatologic disease. He was treated with immunotherapy, and his psychiatric symptoms got better. And so the question that we've been having is whether or not this patient should be in psychiatry, in neurology, or in rheumatology. And so I'm hoping that my work will be able to identify clinically relevant biomarkers that provide a clear path to treatment that allow us to provide precision care for that individual and really understand that particular individual's unique illness. It's an incredible honor to be named a John Watson Fellow and John Watson Scholar. I think what we see is that pioneers not only forge a path, but they keep that path open for people who follow them. And this opportunity would not have been available to me without John Watson's work. And that just makes me ever more aware of the responsibility I have to keep that path open for people who follow me. The John A. Watson Scholarship money really provides an opportunity for us to found this immunopsychiatry clinic in the Department of Psychiatry. It provides the necessary funds to get the clinic up and running before the clinic even has patients. And it's really an investment in the vision of our department in this particular area before we've even had an opportunity to prove out that vision. And so we're incredibly grateful for these funds.